You're listening to ReachMD, and this is COVID-19 on the front lines. The following episode has been brought to you by the American College of Chest Physicians.
CHEST is an internationally trusted source for clinical updates and advancing patient care across the landscape of pulmonary, critical care, and sleep medicine. With clinician members at the center of this pandemic, we are closely monitoring COVID-19 and regularly making resources available to help you navigate the challenges of this public health crisis.
Hi everyone, this is Steve Simpson, the President-elect of CHEST, and we're here with a special visitor this afternoon who has an interesting story to tell us. This is a doctor somewhere in the United States. I don't want to say what town or what part of the United States, nor what hospital. And you will notice that I will refer to our doctor just as doctor, because we are hoping to keep everyone anonymous, our patients, our doctors, our town, and so forth. But our doctor has an interesting story to tell us about what happened in her intensive care unit. And so, Doctor, will you go ahead and tell us what you saw?
So I came on shift, and at that point in time, I was getting turned over from the overnight coverage. And giving the full sign out of a patient, I noticed that there was a patient that had admission for a possible COPD exacerbation or a pneumonia. And during the workup, they had done a flu, which was negative. They'd done an RSV panel, which was negative. They'd done a procalcitonin, which was normal. And so I asked that particular turnover provider if the patient had been put on contact precautions and if COVID had been suspected. And unfortunately, it turns out that it had not been suspected. And so digging further into the story, the patient had initially actually presented about 7 days prior to me seeing him with a fever, did not meet any CDC criteria for evaluation, had a fever, didn't have any real significant cough, but had no travel history, no known COVID contact, nothing like that. So he was giving supportive care and sent on his way home. He'd come back about 3 days before I had seen him, complained of more shortness of breath, more cough, and a COPD exacerbation. At that time, he was put on BiPAP actually in the emergency department. Again, no contact precautions had been taken. So he'd been placed on BiPAP for a brief period of time and was actually able to be de-escalated, but only to high flow nasal cannula. So he briefly went up to the general medical ward for probably about 2 to 3 hours on high flow nasal cannula, started to have a little bit more shortness of breath. So he was then transferred from that floor over to our intensive care unit. He had been in our intensive care unit for about 2 days prior to me seeing him, and about 12 hours of that was on high-flow nasal cannula, and about 12 to 14 hours of that was on BiPAP. And then eventually he was intubated actually the evening before I arrived on shift.
Okay. And let me ask you, in the area before COVID-19, does this seem like this would have been a standard state of affairs and that things would have been business as usual?
Oh, I mean, absolutely. Before COVID-19, there would have been no indication to put this gentleman on any sort of precautions. And for a patient with severe COPD, he had his horrible emphysema, really worse on one side than the left, but bilaterally. That would have been completely standard of care to give a trial of non-invasive prior to intubation. So that would have been well within standard of care.
Yeah, so it would have been basically business as usual. Yeah, so you asked, had the patient been ruled out for COVID-19? And so then when you heard no, can you tell us what did you do and what did you think about that?
So my initial thought was, oh no, because it's a small community hospital. And so the concern is really in small or large community hospitals right now, staffing is a significant concern moving forward. And so there was a potential for multiple exposures throughout pretty much every different level of his care. At that point, I immediately put him on full COVID-19 contact precautions. I did not move him to a negative pressure room because he was already intubated, and there was really no plan to break the ventilator circuit. So there was really no benefit to moving him to a negative pressure room at that time. And he was on multiple drips and infusions because he had pretty severe ARDS by the time that I arrived on shift. So he was on full contact precautions. I then talked to our nursing staff, who had a very similar reaction to me, especially since that particular nurse had been working the day before as well and had multiple exposures to that particular patient. But we all kind of took it in stride and took the appropriate cautions moving forward. Everyone was sort of measuring their temperature and doing sort of a self-symptom check throughout the day. All my nursing staff was. Yeah, and then we contacted the hospital infectious control officer, and then ultimately the health department to get testing moved forward.
Fantastic. And was the test positive?
Yes. So the health department called me shortly after we had contacted him. The patient met criteria not only for testing but for front of the line testing, and we got our result back within 9 hours that he was in fact positive for COVID-19.
And so you've kind of touched on that you and the nurses around had begun to self-monitor. Were there any other implications once it came back positive to the hospital?
Yeah, absolutely. So there are multiple implications. So again, it's a smaller hospital, so the ICU was actually quite small, and he had been in the ICU for approximately 3 days, and essentially had face-to-face contact with about 50% of the ICU nurses,
wow.
maybe a little bit more. There was a potential exposure on the medicine ward. The charge nurse that had been taking care of him the night before had actually called out sick that particular day. So that was a big concern. I'm not sure of her status moving forward, but that was a potential exposure. The ER staff exposures, and it's a huge deal because, the standard line right now is those providers or those potential contacts have to go into home quarantine for 14 days. And so it took out a substantial portion of the staff for 14 days moving forward, including the physician that I was covering for that weekend was supposed to be on shift starting again on Monday. And so you're trying to find sort of semi-emergent coverage to take those shifts.
Wow. And so it sounds like you yourself, when you had the thought, went ahead and began to use personal protective gear, right?
Yes, sir. Yeah. So I ironically had gotten a phone call from the health department. I think it was yesterday or the day before, telling me that I had contact. And I essentially told them I'm pretty much the only one that had contact that is okay, because I was appropriately PPE'd from start to finish. Wow.
Amazing. And so your hospital is following the standard guidelines, it sounds like, of quarantining people with high-risk exposures like this. Have any of those people subsequently become ill?
As I said before, the one charge nurse was ill. I'm not sure what the testing showed on that. And she had been ill with a sort of a cold URI prior to that, was getting better, and then had that exposure and worsened again.
Right.
The physician was actually initially cleared to come back to work early based on negative testing, but is wearing a mask during all shifts and having regular temperature checks during shifts in order to, again, maintain staffing as much as we can. So he was allowed to come back slightly early, but is still under sort of restrictions until the 14-day period is up.
Right. Do you know of any implications in the community, such as patients' family, patients' friends, etc.? Or has
so there's quite a bit of implications. So his wife immediately was on quarantine, and come to find out that she actually had been symptomatic. She had not divulged that until the day after.
Wow.
So she was mildly symptomatic. And then in terms of in terms of public health things for this particular patient, there's huge implications. So his wife told me that he had gone to the dentist the day before he was admitted. So well within that symptomatic period, he was at the dentist and with the exposures there.
Wow.
And when we told his wife initially that we were testing him for COVID-19, she responded with, "That's fine, but I know he doesn't have it. He hasn't been anywhere."
Yeah.
And so this was one of the first community transmissions in our area.
Wow. Okay. So once you made the diagnosis, did that alter any of the care that was provided for him? Did it change anything that you needed to do or were doing for him?
It changed some things minimally. So, he was on pretty significant vent management due to his ARDS. He was already paralyzed from his ARDS. He actually was not that difficult to oxygenate despite the severity of his ARDS. His SATs looked okay, his PaO2 looked okay, which was another thing that sort of raised my thought of, this is not your typical sort of bacterial sepsis or things like that, or, bacterial ARDS.
Right.
Because he was initially pretty easy to oxygenate and ventilate despite the severity of his lung disease. So the vent management didn't change. When I was on all weekend, he was not on any vasopressors at all. That didn't change. The big change is that we started him on Plaquenil and hydroxychloroquine, just
Okay.
because there's some data that might be helpful. And then I put in for the compassionate use to get some remdesivir, and that was approved. But there's quite a delay to get that to your patients.
I see. Fascinating. Does he remain on the ventilator now?
Unfortunately, I got news a couple days ago that he became unable to oxygenate and then passed away.
I'm
briefly.
very sorry to hear that. I'm sorry. Any advice you have for other doctors, nurses, caregivers in hospitals in the United States based on your experience?
Yeah, so I changed, a couple of things based on this case. So, one of the things that jumped out at me was that when he came back with the respiratory failure, he was afebrile that entire time. He had no fevers. The fevers had completely resolved. And so my index of suspicion for COVID-19 now goes up for somebody who has any fever or any respiratory symptoms, period. So I now, in terms of my RTs, basically have shut down nebulizers as much as possible. And if they have to give any patient a nebulizer, even one deemed to be low risk for COVID-19, we're still performing full PPE just for the potential of aerosolizing that. Same thing goes for if a patient needs to be put on BiPAP or high flow nasal cannula. Those patients we're putting into a negative pressure room. Again, even if they're deemed low risk based on the CDC criteria, because my experience for this has shown that there is significant community spread, even if we don't know it, because testing has been so slow. It's hard to know really the true extent of the disease. So my index of suspicion is much higher. And if a patient comes into the emergency room with any symptom of any respiratory symptom whatsoever, or any fever that doesn't have an obvious source, I'm slapping a mask on them pretty much through the gate in order to make sure that my staff are protected moving forward.
Great idea. Is this causing any kind of strain in your hospital? There's obviously more people going into isolation than were previously, I would suspect. Is that right?
There is definitely more people in isolation. There was initially some pushback from the ER staff. They were not happy about losing their nebulizers. But they encountered an afebrile COVID-19 patient, I believe, the following day, and immediately apologized and said they understand why I'm doing what I'm doing now.
Yeah.
So there was initially some pushback because it's a change in how we do business. The pushback I got from the ER in terms of the nebulizers was that we're not following standard of care. And my response is, in this pandemic, there is no standard of care. We got to figure out what the new normal is facing this disease.
Yes.
So that's how we move forward.
Well, Doctor, I want to say two things. One is that you are and have been a hero to your hospital. You've done a lot of good just for the people that are going to present there, and it's fantastic that you have done that. And two, you've taught us all a lesson, I think, in being hyper vigilant. It's easy. I'm wondering, maybe this occurs to you. I don't know if you ever think, oh, I need to stop by the store on the way home from work, and then you find yourself home in your driveway or your garage going, hey, I forgot to stop by the store. It's almost like that. We get automatic. We get very good at what we're doing, and we just do it automatically, and sometimes forget what's going on and what it is that we need to do.
Yeah, I mean, I definitely think that there is something to that. This particular patient had a lot of warning signs that it was potentially COVID-19. He came in lymphopenic. His LFTs were bumped slightly. If you read that Wuhan, China study, he fit in perfectly with the sort of typical presentation of these COVID-19 patients. But I do think it was, the CT scan didn't look typical because his underlying lung disease was so severe. And you just assume, this is just another COPD of the 400 bad COPD patients I see a year, and we just treat them the same way. I definitely think the fact that I didn't start on that case and came in later was one of the big things that let me kind of look at it with fresh eyes as opposed to going down that pathway.
Yeah. We talk a lot about continuity of care, but it is an important thing, too, to have fresh eyes from time to time. Well, Doctor, I want to say thank you very much for sharing your experience with us, and we're going to share your experience with the rest of the United States and, in fact, the whole world, because anyone who has a computer with a web browser can get to this. But we thank you for providing us with a lesson and helping us to up our vigilance and be aware that at any town, any place, this sort of thing can happen, and that we need to be aware that COVID is still on the rise.
I appreciate anything I can do to try to keep providers safe in the difficult months ahead of us is essential.
Well, we appreciate that, and as president-elect of CHEST, I can say if you're not a CHEST member yet, we'd sure love to have you. So I never asked if you are a CHEST member or not, but we would love it if you are.
Yes, sir. I am in fact a CHEST member, so have no fear.
Thank you. So for all of our CHEST members, keep your eyes open. This sort of thing can happen in any town, anywhere in the United States, and we don't want you to have have unnecessary exposures. So for CHEST and for this podcast, this is Steve Simpson again, and we will perhaps be speaking again. Thank you, Doctor.
For the latest CHEST updates, guidelines, expert advice, clinical resources, and more, we invite you to visit our COVID-19 webpage at chestnet.org. Thank you for your service, and please stay well.